Every 30 seconds, somewhere in the world, a baby is born with a life-threatening but highly treatable congenital heart defect. Congenital heart defects, CHDs, are the most common types of birth defects in newborn babies, with over 1.3 million babies born each year around the world. In Africa, chances are that these children may not live to see their third birthdays. Even if they manage to, they will never reach their full potentials if they remain untreated. In Nigeria, an estimated 85,000 children are born each year with CHD. Sadly, less than 200 open heart surgeries are performed yearly on these children. The number is too low, and there are several reasons for this, chief of which is that most parents live below 1,000 naira a day in Nigeria. This is worrisome, but Hospitals for Humanity (HFH) is helping to salvage the situation.
We began Hospitals for Humanities maybe when I was in medical school. We're based out of the U.S. It started probably when I was like 19 or 20. I came back home to Nigeria, and I was hospitalized. And it was because I had I wanted to be like everybody else and drink the local water out the faucet. And the next thing I know, I was vomiting, diarrhea, and it was whatever. And then they took supposedly one of the best hospitals in Lagos, and I was unpleasantly surprised at the quote-unquote better hospitals that we had in Nigeria. So it was at that moment that I decided that this was not going to be the story of Nigeria in healthcare. We have a better story to tell. It takes a lot of planning. It takes the concept is one thing, but then you put that concept on paper, and then implementation becomes another thing, especially in an environment like Nigeria.
As an international non-profit healthcare organization providing free surgical procedures to children born with heart disease, this is a huge relief, especially for parents who can't afford the cost of treatments. Meanwhile, HFH has specifically worked in Nigeria on various healthcare system initiatives. It has screened over 1,500 children for congenital heart defects, performed pediatric cardiothoracic surgeries and cardiac catheterizations in Nigeria on 100 patients, 96% success rate that is comparable to any first-class institution in the world. While providing free open heart surgery is important to HFH, supporting Nigerian healthcare professionals and hospitals with capacity building within the pediatric cardiac space is also a mission. We have been successful in carrying out capacity building of the local medical staff through knowledge and skill transfer from our US-based team of experts. Our goals include creating a nationwide systemic screening program that detects CHD in all infants within 24 hours of birth in Nigeria using the simple pulse oximetry test, and conducting 500 free pediatric open heart surgeries annually for African children.
The only reason why this is even sustainable in the way that it is now is because I recognize that this is way beyond me, and this is way beyond the people of Nigeria. It is so much bigger than that. I think it's a movement, it's a change, and you really have to be able to understand that concept before you do anything. Practically, we're looking at, you have to fundraise.
Today, we have evolving lists of over 1,000 children in our database who have CHDs and need open heart surgery immediately. This list is revolving because open heart surgery. You can make a one-time donation, a recurring donation, or become our corporate partner by visiting our website at www.hospitalsforhumanity.org. Join us on our mission to save children in Africa, one free heart surgery at a time.
Great day, everybody. It's a pleasure to be here with everyone here. We are so excited about today's webinar, and we welcome everyone right here in the room. We welcome our panelists, and we welcome every participant into the room. Today's health webinar is in collaboration with Access Corporation. And we want you to know that this webinar is an episode in the series we have themed Nurturing Young Hearts. I'm sure you got all of that in your invitation. However, before I go on very quickly, I would like to, I don't know, can we open up my video? I've been trying to do that. Please help me open up the video. Today's webinar, like I said, is in collaboration with Access Corporation, and it's an episode in the series we have themed Nurturing Young Hearts. We are delighted because today is the World Heart Day, and today's webinar is in commemoration of World Heart Day. Before I go on with the presentations today,
Good morning all to the panels and the attendees. My name is Dr. Omoniko Akomo, and I am Mrs. Isioma's co-host. I believe she'll soon be rejoining the group, and we'll soon be having the access to be able to let our videos show. But I believe she was in the midst of welcoming everybody, even as we come to celebrate the World Heart Day through this webinar produced by Hospitals for Humanity. If we can just bear some patience, I believe she'll soon be able to rejoin the group once more. Thank you.
okay, very well. I see that I'm back on the screen. I still don't have my video. Please help me check that. Thank you. Yes, and while I was away, I know Dr. Monigo has introduced herself. She's also a moderator for today, so we'll be doing that together. However, before we get into the business of the day, we would like to take a few housekeeping roles. And one of them is that we want you to have a very smooth experience in this webinar. So we would love that you please remain muted. For no reason should anyone be unmuted. If for any reason or technical issues you find yourself unmuted, kindly let us know in the chat or mute yourself. We also would love that the chat room be used to drop questions. Just to put that out there, a lot of our panelists pre-recorded their videos, so you may see that. However, it is so that we do not have any hitches, but all of them are in the comment section. So as you're listening to them, if you have a question, they will be answering you ASAP. So you will be getting your answers, the answers to your questions very quickly. So please do not stop by just answering one or two questions. Kindly bombard these people. They are so knowledgeable. They have all the insights, and they are here to provide those guidance that we need. If you're having any technical issues, kindly reach out to us in the chat room. Also in the Q&A box, we would be giving you the assistance that you require. We will be giving you Great, thank you. We'll be giving you the assistance that you require. Our team, technical team members are very much on ground to assist you and to make this whole webinar a wonderful time for you. Right about now, we are just going to go straight into the business for the day. I'm sure we are excited and we are ready to learn. I am, and I'm sure Dr. Monigo, are you excited about today's webinar already?
I'm definitely excited. We have some great information. It's an information-packed session, so I hope everybody will enjoy and learn as much as possible from this.
Yes, I believe that every one of our participants are ready to learn. Today, our first speaker is Dr. Olawale Olabiyi. He's the Director of Pediatric Cardiology Hospitals for Humanity, and he's also the Chief Medical Director of Pediatric Cardiology Consultants of South Texas, USA. Dr. Olawale, right here, is going to be our first speaker. His profile is on the screen. You can go through it, and then we will flip through into his presentation. Thank you.
Welcome to the World Heart Day webinar series by Hospitals for Humanity. My name is Dr. Olawale Olabiyi. I'm a pediatric cardiologist out of San Antonio, Texas in the United States. And today we'll be talking about nurturing young hearts, a guide to understanding congenital heart defects. Thanks again for coming. I particularly will be talking about understanding congenital heart disease. We'll go through a series of topics. First off, we'll talk about what is a congenital disorder, and then what is congenital heart disease? Who is at risk for congenital heart disease? How is congenital heart disease diagnosed? The prevention of congenital heart disease, if possible, examples of congenital heart disease, and treatment options for congenital heart disease. The current problem we have. The Nigerian population stands at between 200 to 220 million, depending on the statistics you look at. Per the World Health Organization, the birth rate is about 36 per 1,000, given a population with an annual birth rate of 7.9 to 8 million births. Congenital heart disease affects approximately 1% of births. Given that statistic, there are approximately 79,000 to 80,000 births annually occurring in Nigeria that produce children with congenital heart disease. Of those children with congenital heart disease, a quarter of them require intervention sometime in their life. Hence, there are about 20,000 births annually that will require some sort of medical or surgical intervention. In Nigeria, there's an extreme shortage of healthcare workers that can provide this kind of care, and also an extreme shortage of infrastructure. Now that we understand the problem, we'll ask the first question: what is a congenital disorder or disease? Congenital disorders can be defined as structural or functional anomalies that occur during pregnancy. They're also called birth defects, congenital anomalies, or congenital malformations. And these develop during pregnancy. They can be identified during the pregnancy by doing like a fetal ultrasound or scans. They can also be identified later on at birth or later in life. It is estimated that about 6% of babies worldwide are born with some form of congenital anomalies, resulting in hundreds of thousands of associated deaths. However, the true number of cases may be much higher because statistics do not often consider unregistered deaths, terminated pregnancies, and stillbirths. So what is congenital heart disease? Congenital heart disease is known as a series of structural and functional lesions that affect the major blood vessels and the heart itself, and it occurs during the period of fetal formation. So during pregnancy, as the baby is being formed and all the different structures are being formed, you have an anomaly that occurs where the different parts of the heart and different parts of the blood vessels do not form properly. Congenital heart disease is responsible for about 1/3 of congenital aberrations, and it is the most prevalent type of congenital disorder that is known. The most commonly stated statistics for congenital heart disease in the United States is anywhere between 8 to 10 out of 1,000 live births. So up to about 1% of the population. The global disparities in congenital heart disease incidence have been reported to be between 7 and 9 to 10 out of 1,000 live births in Europe and Asia, respectively. Looking at the ICD-9 classifications for congenital heart disease, 25 different congenital heart disease subgroups, and out of those, 21 of them require specific structural or hemodynamic treatments. So how do we diagnose congenital heart disease? It is diagnosed primarily via postpartum clinical examination. So when the baby is first born, you can listen to the baby, you can get oxygen saturation, you can get the breathing rates, you can see how the baby is feeding. A lot of those issues that occur with congenital heart disease occur within the first few months of life. Some issues occur within a couple of days, and you can quickly know that the baby has a heart condition. Some of those issues occur later on. So a baby might go home initially and look fine when they leave the hospital, but can then develop symptoms later on. So things like getting an oxygen saturation is key in helping to diagnose some forms of congenital heart disease in the early on part of the neonatal life, in that first 30 days of life. So apart from the physical exam, apart from getting oxygen level, apart from the breathing rates, and also seeing how the baby's feeding, we can also do a postpartum electrocardiogram and echocardiogram. You can also have a prenatal screening for congenital heart disease, where you do an ultrasound of the baby and looking at the baby's heart while the baby is in the mother. So it's a fetal ultrasound that can occur in the second trimester of pregnancy. And it really helps if you can do this and diagnose congenital heart disease early on, because all of the clinical manifestations that I talked about before, the breathing fast, the difficulty breathing and stuff, if they occur too late and it's not noticed early enough, it can actually affect the survival of the baby. So it is key that early diagnosis is essential, so it can help in better mortality and better survival. We want our babies to survive, and so early diagnosis is key if possible. So the postpartum electrocardiogram is when we get electrodes and place it to the child's chest. We can do it in infants, we can do it in young adults, we can do it even in adults also. The electrodes are attached to the patient, and those electrodes transmits the heart electrical activity. Everybody's heart has some form of electrical activity. And so the electrodes attached to the chest transmits electrical activity to a machine. The machine creates a pattern that represents the heart rhythm. And as you see at the bottom of the screen on the left, that heart rhythm is a normal electrocardiogram, a normal ECG. Using this, we can also then diagnose aberrations in the electrical activity of the heart, where some babies are born with an abnormal electrical system right from birth, and can also give suggestions towards different forms of structural anomalies that they have. You can then do a postpartum echocardiogram, where you're performing an ultrasound of the heart and looking at different parts of the structure. Over here in this picture, we have the 4-chamber view of the heart, and we have the ventricles on top here, and the atria at the bottom. There are 4 main chambers, two atria on top and 2 ventricles at the bottom. And in this structure, you have a valve that's leaking. So echocardiogram can help us to see if valves are leaking, if there are holes in the heart, if there are abnormal structures, if different things are obstructed. And it's a non-invasive test, doesn't have any radiation, but it's very useful in diagnosing congenital heart disease. You can also do things like CT scans, MRIs. A CT scan does have radiation, but sometimes that can help in defining the structure of the type of congenital heart disease a patient might have. Those are more invasive and more involved, but an EKG, an electrocardiogram, and an echocardiogram can be easily available in lots of different centers across the country if we do have the infrastructure for it. So how is congenital heart disease prevented? In all honesty, you can't really prevent most of congenital heart disease. It's just part of the aberration that occurs in the population, about 1%. However, as much as possible, follow your doctor recommendations. Make sure during pregnancy, you do see an obstetrician, OBGYN. You avoid some teratogenic medications during pregnancy. There were a lot more of these in the 70s, but even up to today, some medications like warfarin, if someone has to take warfarin for a disorder that they have, they can't take that during pregnancy because that can lead to some congenital heart anomalies and also some other congenital anomalies. So it's essential that if anyone is pregnant, they are following along with a provider that's taking care of them and following the instructions for whatever medications they're taking, and also avoiding any kind of illicit drug use, things that can restrict the amount of blood flow to the baby. Like smoking is not good. Drinking during pregnancy is not good. It can cause fetal alcohol syndrome. Illegal drug use, cocaine, things like that can also impact how the baby develops. So as much as possible, we do what we can do, and we work with our doctors. So what is an example of congenital heart disease that is diagnosed in Nigeria? I know most of these terms are going to be terms that just sound like, what is this? Is just medical jargon. But an atrial septal defect is a hole in the top chamber of the heart that causes some mixing of blood flow. A ventricular septal defect is a hole in the bottom chamber of the heart that causes mixing of blood flow. The tetralogy of flow is a combination of that ventricular septal defect and other forms of defects. And it's probably one of the most common congenital heart disease conditions that we see in Nigeria, because some kids can survive longer with it just based on the kind of anomaly. I put the last two, transposition of the great arteries and truncus arteriosus, in there as forms of more severe congenital heart disease, especially the transposition of the great arteries. That's a condition in which the great arteries are switched. The arteries that come out of the heart and go to the lungs are switched at birth. So you can imagine that happens at birth. You have to treat that pretty quickly. If you don't have the infrastructure to diagnose that and treat it, the mortality rate within 30 days is about 99%. So it's essential that we understand that these examples of congenital heart disease do happen in Nigeria, and we do need the necessary infrastructure to take care of them. So currently, what are treatment options of congenital heart disease in Nigeria? They're very limited. Nigeria is considered a low resource community where we don't have a lot of resources available surgical wise and medical wise. There is some medical management that can be done for some conditions, like the atrial septal defects, ventricular septal defects. You can use some medical management. Some of the arrhythmias, the electrical abnormalities, you can try some medical management. But there's some conditions like the transposition of the great arteries that we talked about earlier that require surgery within the first few months to first few years of life. Currently in Nigeria, the surgical options rely heavily on foreign NGOs like Hospitals for Humanity that come in and do surgical programs and surgical missions in conjunction with the local cardiologists, surgeons, and people in town, and we work together. The goal is to provide surgery and treatment and other educational opportunities to our physicians in Nigeria, our surgeons in Nigeria, and continue that continuous education, which is the key thing. You don't just want to do a medical mission, come and go, and not continue to provide an infrastructure. So the goal is to come in and provide that infrastructure of continued education so that in the future, there are more programs in Nigeria. Right now, in Nigeria, there's only one local academic surgical program in Nigeria. In comparison, I live in Texas in the United States, and there are 10 centers in one state, just one state. So you can look at the magnitude, the whole of Nigeria, there's one program. In Texas, there are 10. And the need is immense. We just talked about earlier about 20,000 births per year, but we only have one place that's local. Hence, there's going to need to be more infrastructure, more development, and more trainings done. So, wrapping up our conversations today, establishing a congenital heart disease service is difficult, and it has numerous obstacles. But with problems, it provides an opportunity for solutions. There needs to be a mixture of different organizations and different people coming together. The investment that's needed is going to be both financial and infrastructure. It is quite significant, and it's a long-term and progressive project. But these are our children we're talking about, and we have to provide for them, because taking care of one child provides a whole lifelong impact on them, where one surgery for one child could impact the whole lifelong for them. You do a surgery at 1 year old, and now that kid who would have died before has 80 years of useful life, and they can now impact their community and impact the whole of Nigeria, and it could be the next Bill Gates, who God knows. So to take a combination of NGOs, such as Hospitals for Humanity, that brings in the medical knowledge, people like myself, other surgeons, other professionals, pharmacists, nurses, and we bring in that knowledge and we work with our partners in Nigeria. And also Hospitals for Humanity brings in administrative knowledge of how to build programs, how to build a hospital, how to build that infrastructure. So that is definitely necessary to continue to have the NGOs coming in and doing that while the community is building, while the hospitals in Nigeria are building programs there. It's important for the community to be aware that this occurs. It's not a thing where children don't have heart disease, because sometimes you mention that to people and they're like, wow, children do have heart disease. Yes, babies are born with heart disease every day, but most people don't know until it occurs to them or someone that they know. So we're trying to bring community awareness that this does occur, and the community does need to support this because we're trying to help all our Nigerian children. Finally, it's going to also take a combination of governmental support, where there's a mixture of public and private partnerships. Bringing the knowledge from the private sector, mixing it in with the government, and providing long-lasting solutions that can be that long-lasting, long-term, and progressive infrastructure that is necessary and needed. This is the way we counteract this, and we actually make an impact upon our Nigerian children and make an impact that's lifelong. So together we can make a difference, and to take all of us to do this. All of us, both in Nigeria and the diaspora, everywhere, working together to work for our Nigerian children. Thank you very much for having me today, and we look forward to hearing your questions in the question and answer session. Thank you.
Thank you, Dr. Wale Olabi. That was riveting presentation. I think we've all learned a lot about congenital heart defects. Just a little bit of housekeeping before we go forward with the webinar. Just remember to have respectful communication. You want to refrain from any type of offensive or discriminatory or disrespectful language or behavior. Also, if you have any questions, please use the Q&A feature to put your questions in. We will answer possibly a few questions in the Q&A, but most of our questions will be reserved for the end. And keeping in mind that we do have a very tight schedule because this is action-packed just for you. Try to keep your questions concise, and we'll do our best to address those mostly at the end. And now we'll go to our next panelist. So our next panelist is Dr. Queenette Daniels. She is the Assistant Director of Pediatric Cardiology at Hospitals for Humanity. She's also the Chief Pediatric Cardiologist at Kefi Medical Center in Kefi, Nasarawa, Nigeria. She attended the University of Benin, and she also had a residency in pediatrics at Luth. She's also had her master training program in pediatric subspecialties in pediatric cardiology at the University of Padova, Italy. And she has a special interest in non-invasive imaging, and her special interest is in fetal echo and also in interventional cardiology. We're thrilled to hear from Dr. Queenette Daniels about signs and symptoms of congenital heart defects.
My name is Dr. Daniels Queenette. I'm a pediatric cardiologist working in Federal Medical Center, Kefi, and with Hospital for Humanity. I'm welcoming everybody to this World Health webinar series being organized by Hospital for Humanity. And my topic today is on the signs and symptoms of congenital heart disease. From previous speakers, I'm sure we already have an idea of what congenital heart disease is. And wait, okay, no, sorry. We already know what congenital heart disease is, so I'm going to be talking about the symptoms and the signs we get. So as a matter of introduction, symptoms are the presenting complaints, the complaints that the parents or the caregivers or guardians of the children with congenital heart disease will present with. Why the signs are what the doctors or the health team seeing those patients will elicit either from the history they've taken, the physical examination of the child, and also from investigation. Now, it's important to note that signs and symptoms is really required to make a clinical diagnosis, and it needs a high index of suspicion and a systematic approach because they can coincide with other pathologies, not necessarily congenital heart disease. Signs and symptoms are also pointers of complications of congenital heart disease. So it's important to have them and the possible cause of the congenital heart disease. It's important to know that congenital heart disease can be a cyanotic or cyanotic. I'm sure that has been explained. Now, some of the symptoms we have in congenital heart disease will include cough. This cough is usually recurrent. Fast breathing. Every mother will notice that this child is breathing fast, more than probably her other children or other children she had seen. And sometimes they'll tell you the child has difficulty in breathing. This child, usually the parents can tell you is sucking poorly. So when the mother puts to breast, the child cannot suck well. He probably sleeps off while sucking because he's really tired. And as a result of that, he has poor feeding. Some children will have excessive sweating, especially during feeding, and this sweating is on the forehead. Despite whether they're eating well or they're not sucking well or they're even sucking well, some children will have weight loss. They poorly gain weight. In some rare conditions, you see them having overweight, especially when there is what we call edema, fluid collection in the interstitial tissue. So some can have some abnormal weight gain. Now, some other symptoms that the parents will notice or complain, but sometimes is less frequent for parents, except you push or you ask before they can tell you, is cyanosis. Cyanosis is the bluish discoloration of the skin or the mucosa of the mouth. So the child turns bluish sometimes or darkish most times. Finger clubbing is how the hands, the fingers are shaped or digital, both the hands and the feet. You just notice some abnormal shape. The chest asymmetry. So when you look at the chest, or the mother will tell you one part of the chest is bulging, one part of the chest looks like a pigeon, one is beating abnormal. Parents can say that, but most times they might is less frequent for them to detect it. Chest pain, easy fatigability, that's tiredness. This tiredness in newborn, you see it, like I said, during sucking. So they sleep up, they get tired, they feed for a long time. That's feeding difficulty. And palpitation, is subjective awareness of the heartbeat. You can get the heartbeat when you do exercise, but when it is always there, especially during rest, it becomes a problem. Autopnea is when the child cannot lie flat without finding it difficult to breathe. Syncope is when the child faints or feel like fainting, and this you find in older children that have a congenital heart disease. Now, when it comes to sign, like I said, sign is what the doctors elicit, and they elicit these from the history they take from the patient, from the parents or the caregivers. So most I've already mentioned presenting complaints, what they will always complain. But other things they will want to take is the maternal history. Like I said, it can give you the cause and it can also give you the complications. So the herbal concussion medication during the first 3 months of life. Maternal infections is also known, like mothers who have rubella and all that, rubella, herpes. About 1% of them have the risk of having children with congenital heart disease. So the mother can tell you, oh, my daughter once told me when I was pregnant that I have an infection that causes rubella. Maternal conditions like mothers who are diabetic, diabetic mellitus, can have children who have congenital heart disease, and past medical history, like previous spontaneous abortions. And it's known that in such cases, even mothers who have congenital heart disease have a high risk of a child with congenital heart disease in general population, increasing from 1% to like 15%. Now, the weight of the child at birth, which a doctor will ask, also can be a sign that the doctor can see that yes, there's some form of congenital heart disease going on, like prematurity is known to cause patent ductus arteriosus. Macrosomic babies can have hypoplastic left heart syndrome. When microsomia means when they are very big, more than 4 kg for their weight, and found most times in mothers with diabetes mellitus. Now, the family history, you have siblings or relatives who have had congenital heart disease. They have like 3 times higher risks of having congenital heart disease in those children. Like I said, your signs can also tell you complications, because most times in Nigeria, we have children that present late. So by the time they're presenting with complications. One of the complications, common one, is congestive heart failure, and this is due to hemodynamic abnormalities. So in these cases, you have cough, tachypnea, that is fast heart rate, dyspnea, difficulty in breathing, and this is worse on exertion, like I said, for newborn when they're sucking. Sucking is a form of exertion. Older children, maybe they're climbing staircase or they do some little exercise, they find difficulty. Facial puffiness, not so common in children, but can still occur when they have heart failure. Like I already said, poor feeding, excessive sweating on the forehead when they are sucking, wheezing and failing to thrive. Symptoms like raised JVP, which the doctor will elicit when he's examining you, and tender hepatomegaly, that means the liver is large and painful. Pedal edema and ascites, the swelling of the leg. Ascites has to do with something with the abdomen. So these ones you find mostly when you have right heart failure. So they are all signs of congestive heart failure. Now, the conditions that can cause congestive heart failure, you have ventricular septal defect, VSD, PDA, you have total anomalous pulmonary venous returns, even some cyanotic congenital heart disease that has an increased pulmonary blood flow. I must suffice to say that congenital heart disease can be either cyanotic or acyanotic, or acyanotic. So I've mentioned that. So some cyanotic, like tetralogy of Fallot, can also present with congestive, or troncos can have congestive heart failure. And these are the signs, or the signs that the doctor will elicit. Now, another complication is recurrent chest infection, bronchopneumonia. So you hear most times your child is being admitted all the time, bronchopneumonia. It's time to check the heart, because this is increased due to increased pulmonary blood flow. So, and this is also common with children that have Downs, but congenital heart disease can cause that. Other complication, you have cyanotic spell. I've said what cyanosis is. Also squatting. Squatting helps to relieve the symptom. And then finger clubbing, which I've said is due to long-standing arterial desaturation, especially when it's more than 6 months. So there are various levels, and that's the doctor will pick. Other complication, you have shock. So when the doctor checks, the capillary refill will be low. And then arrhythmias, abnormal reading of the pulse when the doctor takes it. Now, when the doctors are going through that, physical examination, it becomes very important. Physical examination can be general examination or can be cardiovascular examination. Other examinations are important, but these are the ones that are can be more specific to congenital heart disease. So when I say dysmorphism, you see children like Down syndrome, they have abnormal foci. The doctors will tell you, oh, even you will see that this child, the features of this child is not looking like what I know as a parent. So, but the doctors will actually pick and tell you, oh, this child has a Downs, or this child has an Edward, or something, dysmorphism. By examining the patient, you can get the nutritional status, whether it's malnutrition or overnutrition. Like I said, malnutrition is common. Overnutrition can also occur in some of the congenital heart disease. The color is important. Like I said, in cyanosis, we'll give you things telling you there's cyanotic congenital heart disease, for example. Dyspnea, difficulty in breathing, fast heart rate, clubbing, sweating on the forehead, edema can be the things that signs that the doctors will pick out when examining the child. Now that's by inspection. Now the doctor will also do what we call palpation when the doctor is touching you. So you have pulses. The pulses can be fast, what we call tachycardia, increased heart rate. That you find in children with congestive heart failure. You can have bradycardia, that's low heart rate. In some cases, like corrected physiology over transposition of the great artery and heart block. Reading the pulse when the doctor checks, he wants to know the reading. Is it regular or irregular? They all have signs of telling me if there's an arrhythmia. The volume of that pulse also means a lot. If it is weak and is steady, you find in heart failure, in shock, it can be pounding. So when you have a patent ductus arteriosus, the capillary filling time, the doctor will check. The blood pressure will actually tell you the pulse pressure and can give you some information. Another thing the doctor will do is to put a pulse oximeter that will tell you the saturation of the child. If the saturation is poor, that tells you some form of cyanosis, and if it's good, sometimes you find in a cyanotic congenital heart disease. Now, cardiovascular system too will involve inspection. Now you're inspecting the arterial chest wall. Like I said, some mothers can pick it up. You see this one part of the heart is bulging, especially the left side, and this you can find in cardiomegaly. Sometimes you see the heart that we call them, that area of the heart, the chest is just pulsating. That tells you there's a volume overload, as you see in conditions like a PDA or ventricular septal defect or even mitral regurgitation and all that. The chest can also look like a pigeon chest. You know what a pigeon looks like? Pigeon-shaped chest. That's found in large left-right shunts, like you have in all the large VSDs. And also you can get that if you have pulmonary hypertension. Now, apart from that, in cardiovascular examination, you also do palpation. So you want to check the epical impulse, okay? You see the doctor put their hand on your chest wall. They want the epical impulse to see if it's displaced, that you find in cardiomegaly, or if it is heaving, okay? That tells you there's volume overload, okay? So that defect must be large. Or it can be tapping when there's a pressure overload And then the apex beat the lowest maximum area of the heart. And the doctors will always check if it's displaced, like in heart failure and congestive heart failure. Trill is what we call a palpable murmur, and it gives you a lot of, it tells you at least the grading of the murmur. So jugular venous pressure, the blood pressure, like I said, will also be checked because it gives you the pulse pressure. When it's increased, when the blood pressure is increased, it tells you there's maybe some form of PD or aortic regurgitation and many other congenital defects. It could be decreased when you have shock or congestive heart failure. Now, another thing the doctor will do is to take the stethoscope and listen. So they are listening for the heart sound. Okay, you have first, second heart sound, which are usually normal. But cases in heart failure where you have what we call the gallop reading. So there's a third heart sound and there's also a fourth heart sound. Once there's a fourth heart sound, there's definitely a problem. Okay, and most times it can tell you there's a congestive heart failure. Okay, other sounds you can get is a click, and then majorly is you can get murmurs. There are different types of murmur depending on the type of congenital heart disease. It's known that when you have a systolic ejection murmur, you're thinking of something like an AS. If you have a pansystolic murmur in your left lower sternal body, you're talking of like a VSD. So part of the signs you have to elicit in congestive heart failure will require you to do investigations. So the ECG, what we call the electrocardiogram, can give you a lot of things. It can tell you the chambers are dilated. It can tell you the heart, the right side of the heart is hypertrophied, like when you have in the tetralogy of Fallot. So it can give you a lot of information. The left side of the heart is hypertrophied, left ventricle is hypertrophied. So the electrocardiogram can give you a lot of information or signs, and it's the doctors that can pick up that, not the parents. The chest x-ray also will give you a lot of signs. When there's cardiomegaly, that's the heart is big. So the doctors can get that. It can tell you when the pulmonary, when there's increased, pulmonary infiltrates, where you, or when it, if it's oligomia that's reduced, that will also tell you in case you're confused. Is this child that is Sano, is it a TGA or is it a tetralogy of Fallot? In TGA is increased, in tetralogy is reduced. So in tetralogy, you have a boot kind of shape of heart. So when you see that, even when you haven't done your echo, you already know what you're up and against. Echo is more definitive because it gives you actual the structure of the heart and gives you all the things, the different heart condition. Now, sometimes in echo, like I said, symptoms can be gotten too late, or signs can be gotten too late. So there is complication already going on. So sometimes you need to do a CT scan, an angiogram, an MRI, all that to just help in giving you the picture of this congenital heart disease in terms of if you have to go for surgery and how to manage the child. Then some condition has to go for cardiac catheterization when they want to know the blood pressures and other invasive procedures. So these are the signs and symptoms that can be associated with congenital heart disease. And if you see any child with any of these, or you have a mother with complaint, because most times they don't present on time, and that's the problem that they cannot help. If any one of these, you just refer the patient to look for a cardiology or to go to the hospital, and from there a diagnosis can be made. Thank you.
Thank you so much, Dr. Queenet, for that very expository presentation. I hope our participants are learning, and we want to see more questions in the question Q&A chat room. Please drop your questions. Our panelists are eagerly waiting to answer all of your questions. Our next speaker will be speaking to us about understanding pediatric acquired heart disease. And our next speaker is in the person of Professor Chris Yogwan. Professor Chris Yogwan is a pediatric cardiologist with Hospitals for Humanities, and is also the Chief Medical Director Plateau State Specialist Hospital, Jos. Professor Chris Yogwan is an expert in pediatric, is a pediatric expert, and is very academic too. Is one that you want to listen to when he speaks about pediatric and maternal health, because he's actually an expert in pediatric and maternal health. Today in this webinar, Professor Chris Yogwan is our third speaker.
My name is Professor Christopher Sabo Yilgwan. I'm a pediatric cardiologist. I practice in Jos, central Nigeria. I'm going to be talking to us, or with us rather, this afternoon on the topic acquired heart diseases in children. Now, acquired heart diseases are actually heart diseases that occur after the child is born. They are heart diseases that occur on a heart that had normally developed. It is different, from congenital heart disease, which is heart disease that develop while the child is in the womb, even though it usually would manifest after the child has been born. In this case, when we say acquired heart disease, we're talking about the heart disease that developed after the child had been born. The child will have grown up with normal heart, or the child will have been born with a normal heart, but something happened either from the environment or from something that the patient took, or sometimes even from food or from some other ailments, that affected the heart and caused the heart to be failing. Now, in children generally, when you consider acquired heart diseases, rheumatic heart disease is the commonest globally, especially in this part of the world where there is poverty, where there's underdevelopment, where there's disorganization, and where there is also poor, and unregulated healthcare access. Kawasaki disease is another, type of heart disease, but it's commoner in Asia and in Japan. Dilated cardiomyopathy, we see it here, especially in children who have had a viral upper respiratory tract disease. Now, when we talk about acquired heart disease in Nigeria, we're basically discussing rheumatic heart disease. Now, what is rheumatic heart disease? Rheumatic heart disease is an acquired heart disease that results, from complications of a poorly treated or untreated sore throat caused by the streptococcal bacteria. Now, when children have sore throat and the sore throat is not appropriately treated, or it is poorly treated, or it is not treated at all, the children may develop, insults to the heart, that results to what we call rheumatic heart disease. Now, rheumatic heart disease mainly affects the heart valves. The heart valves are the doors within the heart and at the exit of the heart that allow blood to flow in between the chambers and also out of the heart. Rheumatic heart disease affects mainly the valves on the left side, of the heart. Now, currently, globally, over 30 million children are affected with rheumatic heart disease. And we see more than 400,000 new cases every year. In Nigeria, the picture is not any different. What are the things that cause rheumatic heart disease? Now, we know that when a child has sore throat that is not well treated, the child may have rheumatic heart disease. However, there are some conditions that tend to make rheumatic heart disease, to continue to exist or to continue to develop. Poverty is a number one, factor that is associated to rheumatic heart disease. In fact, rheumatic heart disease is not seen in countries where poverty is not rife. It used to be a big problem in inner cities in London, in the US, in the UK, and in most European countries. But with improvement in standard of living and economic status of those countries, rheumatic heart disease disappeared. Now, rheumatic heart disease is also, the burden of rheumatic heart disease or the occurrence of rheumatic heart disease is also enhanced by poor hygiene, poor sanitation, and overcrowding. Because sore throat is an infection, a respiratory tract infection, any condition that makes people to be crowded with poor ventilation would increase the spread of that organism. And that has been shown to increase the frequency with which children develop rheumatic heart disease. So poverty, overcrowding, poor ventilation, poor access to healthcare, all these things, poor sanitation, poor hygiene, contribute to the development of rheumatic heart disease. Now, when children develop rheumatic heart disease, how do they manifest? First of all, they manifest with heart failure. Now, rheumatic heart disease and its precursor rheumatic fever is commonly seen in children between the age of 5 and 15 years. When children develop this damage to their heart valves, it becomes chronic and can continue for life. So it becomes lifelong. So you may find adults with rheumatic heart disease, but the disease would have developed in childhood and they live with it for the rest of their lives. So you can see, that rheumatic heart disease is a problem that may occur in childhood. And when it occurs in childhood, the person lives with it for the rest of his life. But rheumatic heart disease can actually be prevented. It can be prevented with simple cost-effective measures. Now, remember I mentioned, that rheumatic heart disease, is caused by a sore throat that is caused by streptococcal bacteria. So if we can prevent the sore throat, or if we can treat the sore throat appropriately, then we can prevent the children from developing rheumatic heart disease. And the best way, to treat sore throat appropriately is by seeking medical care from the appropriate healthcare providers. Most people who have sore throat, or most children who have sore throat, actually take drugs over the counter. And most, if not all, of the drugs that are given to them over the counter does not in any way address the sore throat that leads to rheumatic heart disease. Lozenges does not treat the sore throat. Septrin and all the other fanciful antibiotics that are given does not treat the sore throat. And because the rheumatic heart disease results from the poorly treated, untreated, and non-treated sore throat, the child who has streptococcal sore throat and is not appropriately treated would likely develop rheumatic heart disease. So during this World Heart Day celebration, our message to parents, our message to the public, our message to guardians, teachers, and the general public is that a simple sore throat can lead to a deadly heart disease. And this deadly heart disease can be lifelong. Now, when this rheumatic heart disease becomes chronic and lifelong, severe, it will need heart surgery. And the heart surgery, it's only to ameliorate, meaning to reduce the problem. It doesn't cure it. The heart surgery costs millions of naira, but the prevention and treatment of the sore throat costs less than 1,000 naira. So my message to us this afternoon is, please, when a child has sore throat, take the child to go and see a doctor. Let the child be treated appropriately so that we avoid the chance of the child developing rheumatic heart disease and then becoming disabled or debilitated for the rest of their lives. Thank you very much, and God bless.
Thank you to Dr. Christopher Yogwan. That was a very great informational session about acquired heart diseases. I hope everybody's enjoying and learning a lot from this. We know that you've been getting a lot of information thrown at you. So now we're going to pivot a little bit and give some personal story. This next personal story is from Ms. Damilola Oladimeji, and she's going to be talking about her experience. She's a beneficiary of free cardiac surgery by Hospitals for Humanity. Please enjoy and listen. Thank you.
Hello, good day. My name is Favor Damlala Oladimeji. I am a student of the University of Abuja, and I'm currently in 200 level studying educational management. I was a child that suffered from hole in the heart right from when I was little. I had issues with my health, and I was later diagnosed that, okay, yes, this is what's wrong with me. I went from one hospital to the other, I was always admitted, I was on drugs, I couldn't participate in a lot of activities. And that really made childhood very, very, very depressing for me. Then I also encountered a lot of, there was a lot of even pastors saying that what was wrong with me is even spiritual self, because of, there was not much enlightenment at that time of my issue, my condition. So while my parents relocated to Abuja, we were introduced to this pediatrician cardiologist who introduced us to Dr. Ajayi of Hospital for Humanity. And, it was 2015. I was 13 years old at the time when I had my surgery, Monday, 11th August 2015. And I was booked for surgery. I went in for the surgery. Everything changed, like my body, my system, everything. It changed for the better, actually. It's something that I'd never experienced before. So I was scared. I was very, very skeptical about it. Like, what will happen to me? And then people were telling my parents that I'm too young, that they should allow me to grow, all these things. So there was a lot of fear at the time. But eventually, summoned the courage and I went in for surgery. After the surgery, I started recovering. My recovery was very, very fast. Like 2 weeks after my surgery, like my life went back to normal. Like everything was just perfect for me. Then I didn't even take any drugs anymore. Like there were a lot of, like I was on drugs for over 13 years of my life. Like every day. I cannot go out without taking drugs. Like I even had a medicine bag, that's what my dad used to call it, and I had to take my drugs every day. But after the surgery, the highest thing I'd even take is Panadol. Like I did not even take any other strong medication. It has been 8 years since that surgery. I've not been hospitalized for any heart-related issues. I've been living my life very, very well. I've been adventurous. I've been exploring. Life is exciting now. Being able to move at the same pace with my peers and not being held back because of one issue or the other. HFH is a foundation that assists children like me, like children that are in this heart-related condition and they have issues with their hearts. And they were able to come into my life and I would say relieved me of a bondage, like helped me to live my life to the best potential, because there were a lot of things that I would even have done if not for the surgery. Like there are a lot of things I would not allow to even do at the beginning. but HFH broke that stigma around. And then, you know, even during my surgery, during my stay at the hospital, I met with some of the nurses. I really can't remember their names, but they were very, very nice. And they didn't feel like, they didn't create a hostile environment for me, like as if, yes, so I'm going for heart surgery. It just felt like, even there was the woman that actually came to carry me from my ward, she was just like, don't worry, you'll be in and out. Like, it was very, very, the environment that HFH created for the children alone was magnificent, actually. And my advice to parents out there is that you should allow yourself, my advice for parents with children with health condition is that you should be encouraged as one. Don't lose hope on your child or on your spouse or whatever. You should be also open yourself and allow yourself to be enlightened about things and issues like this. Because a lot of parents have children that are always falling sick and they don't know that, okay, this is exactly what is doing them. And even when they even find out, they are scared to even make a move and book their children for surgeries. They are afraid of surgery. When they hear surgery, they're like, but surgery is not the end of the world, actually. And HFH has been proving that for the past years with successful surgeries, children who were in bondage, they are freed. HFH have proven that these things are possible for children to gain their lives back and live the rest of their life happy, free, and agile enough to achieve their goals. My ambition when I was little was to be a lawyer. And there was a time where even when I was in JS2 I was in primary 5, sorry, at the time. I mean, I'm like, I'm going to be a lawyer. They're like, you cannot even stand for long. How you want to do law? You just faint. That kind of joke. Yes, it's a joke, but it hurts me at the time. And they were not actually wrong, because at the condition I was at that time, but I'd grown up with it. I cannot even stand for long. I couldn't experience stress. But now I can say that even if I'm studying something else, I'm still going to be able to achieve whatever I put my mind to, because now I have the energy, the strength, the hope that, okay, anything is possible.
So good. It was so good listening to Damilola, one of our the people that had benefited from our heart surgeries. Damilola is doing so well in the University of Abuja, and we are so proud of her. We are so proud of her at Hospitals for Humanity. Very quickly, we're going to go into the next sessions of presentations. However, I just want to make welcome Access Corporation representative, Esther Graham. Welcome. It's not time yet for speaking, but we just wanted to make notes that you're here. Thank you for showing up, and we expect the other members of your team. Just very quickly, and I would want to just introduce our next speaker. Our next speaker is incidentally my co-moderator. I told you she's going to have to speak to us today. Dr. Omonigo Ikomu. Dr. Omonigo Ikomu is a global development clinician at Hospitals for Humanity. She's also pediatric cardiologist in San Antonio, Texas, USA. Dr. Omonigo is, she grew up in Lagos. And started her.
Hello, everyone. Welcome to the Hospitals for Humanity.
Great. Dr. Monigo, I think we are going ahead of ourselves. We really want to listen to her. But we'll just take a chill pill and just introduce her to us. Dr. Monigo, like I said, is a U.S. pediatric cardiologist at San Antonio, Texas, USA. And she excels in cardiac catheterization. She began her academic journey in Lagos, Nigeria, achieving her honors. And then she went to Southern Illinois Medical School, where she also graduated as a medical doctor. Dr. Monigo has worked in Reddington Hospital. She also later worked at the Children's Hospital in Philadelphia. She's also served, at different points with medical missions, like the one at Hospitals for Humanity, and also Slum to School. She was medical director of the medical outreaches at Slum to School at some point. Yes, and we are proud and very delighted to have Dr. Omonigo speak to us as our fourth speaker for the day.
Hello, everyone. Welcome to the Hospitals for Humanity World Heart Day webinar. And we thank you for joining us here today, even as we celebrate keeping our hearts healthy. My name is Dr. Omonigo Ekomo, and I'm a pediatric cardiologist. I've had the privilege of working both in the US and in Nigeria as well. And I'm currently working in San Antonio, Texas, trying to keep children's hearts healthy. My topic today is treatment options for congenital heart defects. And I'm going to share my screen right now. So by now, I know that you've heard a lot about congenital heart defects, from the types that are out there to different signs and symptoms. I'm going to focus on the management and things you can do to help the heart get better. As speaking about congenital heart disease management, we know that congenital heart defects can range from simple defects managed with medications to complex congenital heart defects that require complex surgeries to improve the morbidity or how the patient does and also to promote survival. Knowing that, especially when you're talking about the subject of drugs or pharmacotherapeutics, it's very important to work closely with the pediatric cardiologist to determine a good plan for your child. Medications are used in several congenital heart defect patients. It's used most of the time for temporizing the child to maybe delay surgery, especially in very young or fragile infants or children, or in children who are not eligible for surgery, unfortunately. These medications can also be used to manage patients who are in heart failure. A lot of times when they're managing them for things like heart failure, you are, in a lot of cases, the endpoint is going to be a transplant type of surgery. But especially because having hearts for transplant is, it can be rare to get it. It might take a while where you have to depend on these medications to help the children through that time. You might also have drugs that are being used to help with arrhythmias or heart rhythm problems. Common drugs that are used in a lot of kids who have heart failure issues include things, and these are just names that would mean more to patients and families who currently have congenital heart defects, but these are the ones that would commonly come up. Things like Lasix. Lasix and chlorothiazide will help more with reducing the flooding of the lungs from problems with the heart. ACE inhibitors are called afterload reducers, meaning that they reduce the pressure that the heart is pumping against. So they're very nice for that. So Sildenafil reduces the pressure in the lungs. Digoxin is a medication that's used for helping the heart contract adequately, and also it helps with different types of heart rhythm problems. Spironolactone also helps with heart failure. Propranolol and amiodarone medications that help with heart rhythm problems as well. Important other things to note is if your child or family member is having to be on these medications, is give it as instructed. Try to keep the instructions given to you because they're very, very precise medications that if you change too much what is instructed, you could change how it affects the child's heart. You also definitely want to inform your cardiologist if there are any side effects or any concerns, or even if you're having problems with giving the medications as instructed, let them know before you make any changes so that you have a good outcome. The next thing I'd like to talk about in terms of congenital heart defect interventions or treatment options is cardiac catheterization intervention. Cardiac catheterization is a non-invasive procedure. It's important for diagnosis and intervention. Several years ago, cardiac catheterization was very important for being able to clearly see or clearly describe children's heart defects. But now with the advancement of echocardiography and different other imaging modalities, things like MRI that you might have heard of, cardiac catheterization is no longer the main tool for being able to clearly see a child's diagnosis in their congenital heart defects. However, in some cases, especially in children with very complex congenital heart defects, it's still very helpful. So it can be helpful for diagnosis, especially if you have a lot of questions. It's also very helpful with intervention, and this is the main thing that it's being used for today. Congenital heart defect interventions like cardiac cath intervention, it uses catheters, which are the size of IVs, and different wires, which are really small, like the size of a needle. And they also use dye with X-ray fluoroscopy, and that's used to be able to visualize different parts of the heart and also to be able to move through and navigate and to make different types of interventions. For these heart defects, anesthesia is usually important to keep the patient safe. So it means that the child will usually have to be put to sleep, and this would be one of the things that can affect children's risk because they have to be asleep. But it also helps because they're able to be safe while doing the procedure. Therefore, you don't have them jumping off the bed, and they're able to safely perform the procedure, and that's very important. Over here, I have this image. And basically what this is showing is one of the large blood vessels in the heart called the pulmonary artery that takes blood to your lungs. And this is another very major blood vessel in the body called the aorta that takes blood to the head, neck, the extremities, and they are connected by this thing called a PDA. And basically, you can see this is a catheter like what I'm describing. You see it's much smaller than these blood vessels, but with this dye, which is the thing that's making this dark, we're able to look on X-ray and we're able to see that this is the way it is, and this is the PDA. Using this type of technology, we're able to deliver a device here, and then we can close this off if it's causing problems in children. And the newborn babies who are premature, or even just newborn babies, it can definitely cause problems. And you're able to do this procedure without doing a full surgery, without doing a surgery, and you're able to have the child have a better outcome. So it's very interesting and exciting procedure. Here, this is a procedure that's done more in adults. It's called coronary angiography, and basically it means that we're using this catheter here, and these are the coronary coronary cardiac blood vessels, and where here you are using dye to be able to see what the blood vessels look like, and then you can make an intervention this way as well. So here I have just a few of the benefits of cardiac catheterization compared to surgery, because both of them can do some things commonly, and there are things that some like surgery can do that cath cannot do, and vice versa. So the multiple cardiac defects that are once treated only by surgery, now you can consider doing a cardiac catheterization for them. Not all of them, but a good number of them. The other thing about cath is that it can be considered to be cheaper than surgical intervention, but it really depends on the location. Over here in the US and most of the developed parts of the world, it's definitely considered cheaper. However, issues that we've been seeing, especially in developing countries, is that because you have to import the consumables to those locations, and they might get the consumables at a premium, it ends up being even more expensive than cardiac surgeries. That's if the center already has a bypass lung machine. So this is just in some locations. Something else that we see in cath compared to surgeries that usually have quicker recovery times. For most of the procedures that you have might be 1 to 2 days recovery. However, if children are very sick at the time that it's done and they have very complex hearts and we're just very sick in general, a lot of times what you're still waiting for is recovery from their overall condition, as opposed to just recovery from the cath. Also, as expected, if there are any complications that happen with the cath, that might also prolong the recovery time. But on the most part, when things go well, the recovery time is much faster than what you have for surgery. Another big benefit is that there's no surgical scar involved in cardiac cath, and that's a big deal. The surgical scar in surgeries, well, for one thing, it's very visible. The other thing is that once you've had it, and if your child winds up needing lots of different surgeries, every time they have to go back in and open that chest and reoperate on a scar, and that increases the risk for the child. However, with the cath procedure, when you do it, there's no surgical scar. And if you have to do it after the surgery, you don't have to reopen the chest, and the risk is not increased from that standpoint. So that's an important thing. Some of the disadvantages or other things to be considered of cath compared to surgeries are for cath, most of the children who have cath procedures to do interventions will require lifelong follow-up. So if they get a device in either one of the heart defects, you usually have to keep watching that device, make sure it's in a good position and that they don't sustain any type of complication or any kind of issue from that device. Meanwhile, for some surgeries, you don't have to follow all their lives. You follow for a short time, a couple of years, and then you might not have to continue following all the time. So that is a difference. In some cases, cardiac catheterization is not definitive, meaning that it doesn't just finish the whole chapter. You might continue doing other things. But in a lot of instances, the cardiac catheterization is very adjunctive to surgery as well. So that sometimes if a child is not considered if a child is not considered to be viable for surgery, you can possibly do a cardiac catheterization that can help the problem at least to some specific degree. Another issue is radiation exposure, because you have to use X-rays while you're doing the cath. Like I'm showing here, the X-rays that were used to show this, that just increases the radiation exposure quite an amount, where you don't usually have to do that for surgery. But I will say that in most of the developed world, they're now coming up with different options to reduce that radiation risk. And some places are using things like MRI to do their cardiac catheterization so that they're cutting down radiation exposure risks. These are specific cardiac interventions that we do, and I'll just run through these quickly. We can do a valvuloplasty or balloon valvotomy, and basically what you're doing is that if you have a narrowed valve, you use the different special catheters and use a balloon. You basically use it to try to open up the valve at different pressures, and that way you're able to have good flow of blood, which is one of the major things that we have to achieve in cardiology. Angioplasty, a lot of times that's what's used for people who have these coronary artery narrowings, and they use a much smaller balloon and they use the catheters to go in and to try to open up the coronary artery so that you have, again, good blood flow, so that you're getting blood to the heart and you're not going to have heart attacks, and that's when they use that most of the time. For stent implantation, again, if you have a blood vessel, like something like one of the branch pulmonary arteries, again, the pulmonary arteries take the blood to the lungs, and they have two branches, and sometimes you might have a narrowing in that. Sometimes you can go in and just open up that blood vessel a little bit, but sometimes even if you open it, it's going to try to close back down. What you can do to reduce that is called a stent implantation, where you go there and you put a stent that's on a balloon and you leave it there to keep that blood vessel open, and that's going to allow continued blood flow even when you come out. So that's good for that reason. You can also use a balloon and blade septostomy, and these are in most of the time in children with very special and very complex heart defects. What you're doing is trying to create a hole between the top two chambers of the heart so that you have blood flow there for children that have different types of defects that are not allowing important blood flow to specific regions. So basically, you use the catheters and sometimes a blade to create these openings and increase the blood flow between the upper chambers. Valve perforation can be used in children who have a completely blocked pulmonary valve. Again, I've been talking about pulmonary arteries a lot here. And again, these are the major blood vessel that's carrying blood out to the lungs. The valve can be completely blocked where there's no blood flow out. And sometimes once they've looked at other things to make sure that it's safe, they can go ahead and try to open that out. And that will help the child quite a bit. Other things that we do is occlusion of the intracardiac and vascular shunts. I showed you the PDA in that my first slide for cath. Also, you can close an atrial septal defect or hole between the top two chambers of the heart. You can close a VSD, which is a hole between the bottom two chambers of the heart, and I'll show you that in a second. And these are other things that you can do. You can implant a valve now these days by cath. And also, a very big thing is for children that have heart rhythm problems, you can do what's called an electrophysiology study. That just means that you're looking at the cardiac rhythm and trying to figure out where the problem is, and you try to solve it, and that's all by cath. So this is just a nice picture that kind of brings life to what I've been talking about. The atrial septal defects, I told you that's a hole between the top two chambers of the heart. The top two chambers, the bottom two chambers. This again is the artery I've been talking about the most, the pulmonary artery. And here's your big aorta over there. And here there was a hole here, and they were able to basically come up over here with their catheter and they're able to deliver this device here, effectively closing this hole. And when this hole was open, you'd be causing all kinds of problems, including heart failure in the child. But once you put this here, that's no longer a problem. And here you have a ventricular septal defect, which is a hole between the bottom two chambers. That can cause significant problems as well. And here in this situation, again, they've been able to go in with the device and to place this here to block this hole. And then the child is able to do better. But again, like I said, they would have to continue to monitor over a long time. Next big thing is surgical interventions. This is the definitive solution for most congenital heart defects. You might need surgery to repair a hole in the heart, such as a VSD or an ASD, so the things I just talked about. You might need to repair a PDA, complex defects. You might need it to repair as well. You might need to repair or replace a valve or open up narrow blood vessels when you do not get a good result from cardiac cath, or if it's not an option. And then a big thing is that you might need to give a new heart, meaning heart transplantation. The two major types are open heart surgery and closed heart surgery. The open heart surgery needs a heart and lung machine, and that's basically to stop the blood flow through the different heart structures so that the surgeon can see what they're doing. The closed heart surgery, they might be able to do it, and they will not need to actually stop the blood flow and everything to be able to get that surgery done. And this just talks about the operation room team, and again, you need anesthesia. This is these are like 51 different surgical repairs that can be done to help the heart. And I'm just going to try clicking on this one to see if it shows here. That's your ASD, atrial septal defect. They're bringing a patch, they put the patch, they close it, and they have done the surgery to treat the atrial septal defect. So that was very nice. Another one that you can see, it's called for an atrioventricular septal defect. These are the holes between the top and bottom, and they put this patch here, they put another one here, they sew it. They have helped the problem of the child. Okay. I'm going to go back to my full screen. Okay. The next thing I have to talk about is called hybrid repairs. Hybrid means two. You know about hybrid caths. So basically, innovative cardiologists and surgeons can combine their skill sets to fix or improve difficult lesions through a combined approach. And these are some of the things where they can benefit from that. Sometimes they have ventricular septal defects or holes between the bottom two chambers of the heart, which are not easy to access. So sometimes what they'll do is the surgeon will go and open it up, and then the cath doctor will come and put a device there, and they're able to close it that way. Hypoplastic left heart syndrome, sometimes they're able to combine some of the cath procedures I told you about. No, I didn't tell you about this, I'm so sorry. But I told you about the PDA, and sometimes that PDA can be helpful in children who have problems with their big aorta. And what they can do is they can put a cardiac cath instrument to open up that blood vessel so that it can continue being helpful while they do a surgical procedure to help the process along. And sometimes with the aortic valve, you can implant through with surgical access. We have also assist devices, and we have mechanical circulatory support therapies, things like impeller and things like ECMO. These are just fancy names for saying that basically these very complex instruments are used to be able to do everything that your heart is supposed to do. It adds oxygen to the blood, takes out the CO2, and it's able to restore it. Very complex, and I don't think we have it right now in Nigeria, but it is had in developed countries, and the goal would be try to make sure that we have it on in Nigeria as well, or where our children can access it as well. Ventricular assist devices are used in children with severe heart failure, and basically it gives support for what your heart would be able to normally do if it was working better. So children with cardiomyopathies, or very thick or very thin or very engorged hearts that are in heart failure, they will benefit from this. You have the total artificial heart, where again it's doing everything for you, but it's not as complex and as the ECMO, but it is smaller. Pacemakers and implantable cardioverter defibrillators are used to help with children with heart rhythm problems. Pacemaker helps modulate the heart rhythm, while the ICD can be helped to, if for a child who is at risk for sudden death, it can help to give you an impulse, just like it would do if you needed to have the cardioverter paddles, and it's able to shock you out of an abnormal rhythm and potentially save your life. So that is, it's a very, in a nutshell, it's a very abbreviated look at different congenital heart disease treatment options. These are my references, and I'm looking forward to your questions. Thank you.
Thank you so much, Dr. Monigo. We had such insightful learning from you on those CHD ways we could correct CHD that you just told us. Thank you. We see the questions coming. Please keep them coming. We will soon get into our question and answer session, and you really want your questions answered real time. Please let us know real time. You know, you want one of our panelists to talk about your question and then answer it. Please drop those questions in the Q&A session now. Drop them now, because we are collating for that purpose now. Please drop them immediately. We'll go very straight into our next speaker, the very last, I think, the last of our panelists today, before our Q&A. Her name is Dr. Frances Okpokururok. Dr. Frances Okpokururok. And Dr. Frances is a pediatric cardiologist with Hospitals for Humanity, and she's also a consultant pediatrician at the University of Uyo Teaching Hospital. Dr. Frances started her medical career in the University of Ibadan and went on to study public health in the University of Roehampton, London. Dr. Frances serves as a honorary consultant pediatrician and associate professor at the University of Uyo, and she is very, very, very vast. Today, Dr. Frances will be speaking to us at this webinar about support network and resources for CHD. Please make welcome Dr. Frances for her session.
My name is Dr. Frances Okpokururok. I'm a pediatric cardiologist with the University of Uyo Teaching Hospital, Uyo, Akwa Ibom State of Nigeria. I'll be talking to us this morning on support networks and resources that are available in the country for the management of children with congenital heart diseases. Thank you. As you listen. By way of introduction, congenital heart diseases are abnormalities in the structure and or function of the heart that is usually present from birth. The global incidence of this condition is estimated at 1%, and based on this, an estimated 70,000 children in Nigeria are born annually with this condition. The burden of care of these children rests mostly on the parents in our environment, where out-of-pocket healthcare expenditure constitutes about 81%. These surgeries are very expensive, with the average cost of surgery in India being between $4,000 to $6,000 per patient, depending on the lesion and on the surgery that is to be performed. The availability of pediatric cardiology and surgical services within the country are grossly inadequate, with as many as 80% of our patients who require surgical intervention having their surgeries done outside the country. The pediatric cardiologist should be the first in the line of management in terms of making a diagnosis and initial care and follow-up of these patients. Pediatric cardiologists are available mostly in the tertiary healthcare institutions within the country, which are mostly government-owned. We have about 33 of them who practice full-time in 26 centers in the country, out of a total of 48 centers nationwide that were surveyed. We have our first figure here on the screen, which shows us the distribution of participating centers according to their geopolitical zone. And we can see that the Southwest zone takes the majority here, where we have 20.4% of centers being located in that zone. And this is closely followed by the North Central zone. Children with congenital heart diseases of cardiac significance will usually require surgery after initial evaluation, as I've said before, by the pediatric cardiologist. Now, clinical evaluation includes taking a full history, a physical examination, and doing certain investigations, of which pulse oximetry, chest X-ray, the echocardiogram, and the electrocardiogram are baseline investigations. Cardiac catheterization is a more advanced form of evaluation which can be used in both diagnosis and treatment in certain cases. Now, 97.9% of centers in our country which were surveyed had equipment for electrocardiography and pulse oximetry, while about 93.8% could perform echocardiography. Looking at cardiac surgeries, most of the cardiac surgeries performed in Nigeria are usually undertaken as part of medical outreaches or missions in which specialists from within and outside the country collaborate, with some of these missions being subsidized either partially or in full by non-governmental organizations, which may be faith or non-faith-based. We have a couple of advantages of these medical missions to the patients, of which two are that the cost of care is usually subsidized, and sometimes the wait time may be reduced. But a major disadvantage of this is that there is no walk-in service available, especially in cases of emergency. Looking at the resources that are available to us in Table 1, and this is based according to the centers and the zones in which they are located, we can see there that the Lagos University Teaching Hospital, the Lagos State University Teaching Hospital, both of which are government-owned facilities, these are located in the Southwest zone. Reddington Hospital, Lagos, is a private healthcare facility that is also involved in cardiac surgeries. University College Hospital is government-owned. All these centers are located in the Southwest. The Biket Medical Center is located in Osogbo. They also are able to do some surgeries there. For the North Central Zone, we have Garki Hospital in Abuja, while the Heart Scan Center does mainly cardiac catheterizations. For the Southeast Zone, we have only the University of Nigeria Teaching Hospital in Enugu, and in the Northwest Zone, we have the Aminu Kano Teaching Hospital, where cardiac catheterization can be done. In Table 2, we can see the distribution of the number of centers with some facilities and procedures according to the type of hospital. For open heart surgery, we had 4 public institutions or government-owned institutions and 2 private hospitals, giving a total of 6. For cardiac catheterization, we had 6 centers in all, 3 both in public and 3 in private. And across the country, we had 25 intensive care units and 46 ventilators that are available. In conclusion, having a child with congenital heart disease that is amenable to surgery should not be a death sentence. What is required is a concerted effort on the part of both the government and individuals, represented by non-governmental organizations, to make these services available to as many as need them. The focus should be on manpower development, training, and provision of resources. Thank you very much for listening. Below are my references. And in this slide, we have a list of contact phone numbers and emails for those that might be interested. They are also available online. Thank you very much for listening.
Fantastic. Thank you so much, Dr. Francis Okpokoguruk, for your very insightful presentation. I hope everybody was able to get a snapshot of that last slide where it showed different contact numbers and email information in case anybody needs to get access any of these support networks for any congenital heart disease patient or family member or friend. Thank you for your attention thus far. We're now going to move on to another personal story of another beneficiary by Hospitals for Humanity, but please don't leave. We still have more messages and we definitely have the Q&A session coming up in a short time. Thank you.
Good morning, all. My name is Amina Mohammed, and this is my son, Abisana Umar. She was born some 6 years back, born with a congenital heart disease. So, all along, we've been going from one place to another just to get the surgery done. Because they said we should take him to India, Egypt. Unfortunately, I don't have the resources to do such. So, we contacted people, our doctors, our pediatrics, and they connected us to Hospital of Humanity. Some years back, they came, about 3 years back, they came, they did some. Unfortunately, we're not among them, but today, the story has changed. My boy was operated on the 30th of April 2023. And he is sitting down, smiling, and I am happy. As a mother, I'm very happy. I'm so grateful. Hospital of Humanity, long live hospital, the doctors of Hospital of Humanity.
My name is Abdulsalam. Thank you, Hospital for Humanity.
Testimonials. We just listened to Umar Abdulsalam's testimonial. He was one of those children that was part of our surgical operation in the last surgical program that we had in Abuja. And we cannot thank enough all of the collaborators we've had so far, all of the people that have pitched with us with funding to make sure that people like Umar Abdulsalam got a surgery free of charge from Hospitals for Humanities. One of such people and such organization is also partnering with us, our very good collaborators and partners, Access Corporation. And we have right now and right here someone from Access Corporations, actually the head of marketing and communications, Access Bank Botswana, is right here to give a remark from Access Bank on behalf of Access Bank by the name Polelo Kilner. So we would have Polelo Kilner's remark right about now. Please help me open the speaker and video for Instagram, the two Instagrams you can open for them. I don't know which one she's using. So kindly open that for them. Thank you very much. We're about to finish. And just before our Access Bank, yeah, so good. Before Polilo speaks, I would like to, I know a couple of people are putting in the chat room and asking if the slides will be available. Yes, we would be, this whole webinar is recorded and we'll be sending the recorded the link to the recordings to every of our participants. So please do not dismay and don't feel like maybe you've lost anything. We would be sending the link to the recording to your email addresses that you used to register. Right now, we would have the head of marketing and communication.
I apologize. I think there have been some technical issues again.
Hi,
sure
can you hear me?
We can hear you. Please go ahead if you like. I'm sure Mrs.
Fantastic.
will join us. Thank you.
Thank you very much. Ladies and gentlemen, as we approach the conclusion of this profoundly enlightening webinar, I want to extend my deepest gratitude to each and every one of you for your unwavering commitment to this important cause, brought to you by Access Holdings in collaboration with Hospitals for Humanity. The wealth of information and insights that has been shared today holds the potential not to merely inform, but to truly transform lives. The conversations here, I believe, have bolstered our understanding of congenital heart disease, laying the foundation for early detection and improved care. The knowledge we have garnered today is not just data, it's a beacon of hope. It is the spark that ignites early detection efforts, enabling healthcare professionals to intervene sooner and provide more effective treatment strategies. It's the catalyst for improvements in the quality of care, leading to better outcomes and a higher quality of life for those facing this challenging condition. At Access Holdings, we are not detached from the prevalent issues that affect our communities, and we're committed to improving the lives of those around us. Hence our mission. As we leave this virtual gathering, it is clear to take this knowledge and put it into action. Share what you have learned with your communities, your colleagues, and your loved ones. Advocate for routine screenings and awareness campaigns. Support organizations and initiatives that work tirelessly to improve the lives of individuals with congenital heart disease. Let us remember that our strength lies in our unity, and our collective dedication to this cause is a formidable force. Together, we can make a profound and lasting impact on the lives of those who bear the burden of congenital heart disease. Let the information we have shared today be a catalyst for a brighter and healthier future for them. In closing, I want to thank you once again for all your active participation and your passionate commitment to this cause. Together, let us continue to shine a spotlight on congenital heart disease, ensuring that every heart, young or old, receives the care and attention it so rightly deserves. Thank you, and may our shared dedication inspire us all to keep the torch of awareness burning ever more brightly.
Fantastic. Thank you so much, and wonderful to meet you, Esther Graham. We are very appreciative to Access Bank for the ability to do this webinar and to reach more people with information regarding congenital heart defects. So thank you again so much for your attention. You have been an amazing audience. Now we've come to the part that everybody's possibly been waiting for, the Q&A section. I know that people have been placing their questions in the Q&A box, and they've been getting answered in there, but there were a couple of questions that we did highlight, and there's one that we were saving for this last part to be able to answer in some detail. So I'm going to allow, I believe Dr. Labi, who was one of our panelists, is willing and interested in answering a question. Thank you, Dr. Warren.
Good morning and good afternoon, everyone. Thank you once again for coming today and listening to us. Thank you to Access Corporation for working in conjunction with Hospitals for Humanity to do this webinar series on nurturing children's hearts. So there have been a few questions in the question and answer box, and I'll address one of them and kind of wheelies into another question. So it was from Mr. I think it was Dr. Emmanuel Alimeke. His question was, thank you for your presentation. I once saw a patient during medical school who, at the University College of Ibadan, there was a child who had a hemifontan operation in India and developed chylothorax and had financial difficulty traveling back. What are the reasons why patients develop complications after great surgeries like this? And how long does it take a surgeon to be trained to be able to do such surgeries? So the hemifontan operation is a complex operation in which we are treating a very complex heart condition. So a lot of the heart conditions we talked about earlier are sort of straightforward heart conditions. So there's a hole in the top chamber of the heart, hole in the bottom chamber of the heart, a blockage in the valve, something like that. There is a condition called hypoplastic left heart syndrome or hypoplastic right heart syndrome, in which the entire left side of the heart doesn't form well. And it's hypoplastic, meaning it is small and compressed. And the valves don't form well, the chambers don't form well. And so the blood flow and everything involved with that becomes, it doesn't go well. So that condition, if left untreated, would ultimately lead to the demise of the child, and the child will pass away. Well, there are some series of heart surgeries that have been developed that leads to directing the blood flow to the lungs directly, which normally the blood flow goes to the heart first, and then normally that blood flow goes from the heart to the lungs, and from the lungs back to the heart, and then from the heart to the body. That's the normal circulation of blood flow. But in this series of operations for hypoplastic left heart, the blood flow is directed directly to the lungs, and then from there it comes back to the heart and then to the body. Over time, those operations can have some failure. And so it's key, even after surgery, to continue to follow up with your doctors to watch for potential symptoms and signs that can occur down the line and the need for treating them, particularly with this hypoplastic left heart syndrome and the Fontan operation or hemifontan. So a chylothorax is a condition that occurs after a hemifontan or a Fontan operation, wherein people develop fluid in different parts of the body and they have to be treated. And it's a known complication. It's hard to treat. It takes a lot of training to treat it, and sometimes it's unsuccessful. But there's more investigation, there are more medications, there are more interventions to treat that over time, and it requires a lot of training. So that comes to the second question. How long does it take for a surgeon to be trained to do a hemifontan operation? It takes a lot of time. Congenital heart surgery or cardiac surgery in children is probably the creme de la creme of surgery to be performed. The general surgeon takes about 4 years of undergrad, 4 years of medical school, then 5 years of general surgery. So that's 8 plus 5, 13. Then for cardiac surgery, you have to do at least another 2 years. And then for pediatric, you have to do another 2 years. And a lot of times there's a lot of research in between those years. So you could go anywhere from 14 to 16, 18 years in training. So it takes a long time to train. Part of the problem in Nigeria is not just the training, because we have very smart individuals in Nigeria, we know this. Part of the problem is not just the training, it is maintaining that training, having the place to continue to do those surgeries. So we have surgeons who come back home to Nigeria after training in London, overseas, but when they come home, there's no infrastructure to continue to do that surgery. So that's what we need a lot, is a place for those surgeons to consistently do surgery so they don't lose their skill sets. So yeah, it takes a lot of time, but it also takes maintaining that. So thank you for that question. It's a great question, looking at all the critical things that can happen and how to get there. And that lastly, I'll address one question that came up about can interventions occur in fetal life? In fetal life, where the baby is in mom, sometimes you can have interventions that do occur. And sometimes it's for that condition I mentioned again, hypoplastic left heart syndrome. Because of how severe that condition is, some interventions were developed where you can do procedures like cardiac catheterization, like Dr. Omanugo was talking about earlier, and you can do some procedures while the baby is still in mom. It's a very high-risk procedure, takes a lot of teamwork, a lot of different people, the obstetricians, the cardiologists, the surgeons, the interventionalists. So lots of different people are involved in that to get that to work. And it takes a complex hospital system, a complex medical system to do that. Hence, there are only very few places in the world that can do that, few places in the US or in Europe that can do that. Currently, that fetal intervention is not available in Nigeria. Thank you very much. We'll be happy to take more questions or address any other questions that the panelists wants to.
Thank you, Dr. Waller, for taking those questions. I was just going to add to what you said while waiting to see if anybody answers any other question. As far as the fetal interventions, one of the other things that I discussed in my talk was medications, but there's sometimes some kids have some fetal arrhythmias that are pretty bad, and you can give medications to the mom to try to modulate that as well. So just something to add to what Dr. Waller said about the fetal cath interventions. You can also do the pharmacotherapeutic intervention in the way of giving medications to help with fetuses that are having issues in the mom's womb as well.
Dr. Monica, is there any other question? Are we taking anyone else?
I know there was one. I was thinking. I was wanting to shed some more light on the question. Somebody asked a good question about if congenital heart defects are hereditary. I don't know if Dr. Wale wants to shed more light on that. I think that would be nice to address a little more.
Yes, thank you. So that's another great question, congenital heart defects, hereditary. And the known risk of congenital heart disease is about 1%, so, 0.8 to 1%. And that's the general population risk. And so a lot of times that forms or occurs spontaneously. However, if an individual has congenital heart disease, the risk for their child doubles. It sounds big and sounds huge because we could say double, but it goes from like 1% to 2%. So yeah, the absolute risk does go up to 2%. The relative risk doubles. There's just twice a month higher risk for that child to get something. So what we tend to do is, if the parents have non-congenital heart disease, we are a little more alert and at high, alert, watching when the child is in mom. If you have access to fetal echocardiogram, where you can actually do an ultrasound in the baby, looking at the baby's heart, doing an echocardiogram, looking at the baby's heart. If you do have access to that, that is a great tool, because then you can diagnose congenital heart disease while the baby is still in mom. So when the baby comes out, if it's something that is severe, you can have an intervention while the baby is still in mom. So that's one thing that can be done. Also, after the baby is born, you can do an echocardiogram in the first few days of life and verify, if the person does have congenital heart disease and if an intervention is needed. So once again, it's key to do those assessments early on in life, especially if you do know that the parents do have something, and it depends on the severity of what they have. Some of the more severe conditions require more workup and more evaluation versus some of the other defects that you can wait a few months of life. So the risk does double, but it's not the end of the world. We can still address it. We can still evaluate the patient and provide interventions as needed.
Thank you very much, Dr. Labi. It was a pleasure having you answer those questions. Right about now, we're going to be taking the next thing on the agenda, which is a remark from HFH to everyone that has participated in today's webinar. We are so grateful. We see our participants waiting up to the end, and we know that you've learned a thing or two today. And together we will just raise awareness and continue to raise awareness. We'll take that message now, and I'll be back to round up.
Good afternoon, everyone. My name is Pharmacist Opayemi Okoyemi. I'm the lead pharmacist and I'm an executive team member of Hospitals for Humanity. It's nice having you here for the past 2 hours. We've been so thrilled with your presence. Thank you so much for coming. Of course, ladies and gentlemen, you are our esteemed attendees, and Hospitals for Humanity with Access Corporation is giving a heartfelt gratitude to each and every one of you. Your presence, your engagement, your support has been so wonderful. We are grateful for that. Thank you so much. First and foremost, I would like to appreciate you all and express our deep appreciation also to Access Corporation. Your dedication to HFH cause, your commitment to making positive impact and unwavering support have been instrumental in bringing this webinar series to life. We cherish our partnership with you, and we look forward to achieving even greater heights and milestones together in the future. Today, I would like to share a little light on the extraordinary work that Hospitals for Humanity has undertaken since 2014. Our mission has been to transform the lives of children in Nigeria who live with congenital heart defects. And this has been a journey that we have experienced and is filled with all compassion. It has been filled with resilience and hope. And we are glad to be part of that. Through your support, our dedicated team members I'm talking about now, they've been able to provide life-saving intervention, surgeries, and care to more than 130 children in Nigeria. And their families are very glad and happy for this. We celebrate every one of you, and we celebrate the life you have touched, and we remain committed to the vision of a Nigeria where congenital heart defects are no longer a threat to our children. But our work is far from over. We stand at a critical junction at this moment where the battle against congenital heart defects requires the collaborative effort of each and every one of us. We implore each of you, our cherished attendees today, to join us in the noble cause. Your contribution, either through donations, through volunteering, or spreading the awareness, will make a very great significance, and it will be of great help to our children. Of course, Hospitals for Humanity is not only open for collaboration, we are eager to foster partnership that can amplify our impact. We welcome individuals, we welcome corporate organizations, we welcome parents, we welcome guardians to reach out to us. Our website is there, our social media platforms are very active. You can reach out to us, and together we can create a network of change makers that are dedicated to saving lives and building a awesome future for our children. Of course, we extend our gratitude to the entire Hospitals for Humanity team. You guys have been wonderful. Your tireless efforts, your unwavering dedication has made this webinar series possible. We are indebted to all our esteemed panelists. Your expertise, your insight have enriched our discussion and has inspired us a lot. It is your compassion and it is actually your passion that fuels our mission in Hospitals for Humanity. As we close this chapter, and we are excited to announce that another series of this webinar will be taking place February 14th. Let's take note. February 14th is in commemoration to the World Congenital Heart Defects Day. Save that date, because we're going to come together at that period once again, and we are raising awareness, sharing knowledge, and driving action. We eagerly anticipate your presence and participation. In conclusion, we thank you all for your unwavering support, your commitment to our cause in Hospitals for Humanity, and together we can make a profound impact on the lives of children in Nigeria living with congenital heart defects. Let us forge ahead with the thought. Let us go unitedly in our resolve and continue to be the beacon of hope for these young hearts. Thank you all, and may you all remain blessed.
Thank you for Mr. Kwame for that closing remark. And with that closing remark, we've come to the end of today's webinar, the episode of this webinar series. And again, I converge with my co-moderator, Dr. Omonigo. I want to say that you've been a wonderful partner on this webinar side, and we are grateful for all of our participants, everyone in the room, for staying to the end. It's been more than 2 hours since we started, and you've patiently just waited. We're sure that you've had, a wonderful time of learning and, just topping up on what you already know for some that are already aware about what congenital heart defects are. Dr. Monigo, you have something to say before we close out?
Oh, no, you just did an amazing job. So I had to say it too.
Oh,
and
great.
We've had an amazing audience, and we're so happy and thankful to all the panelists and everybody.
Very true. Pharmacist Okoyemi mentioned that we are going to have the next episode of this series. Recall that we said that the series is Nurturing Young Hearts, and this is the first episode in that series. We're going to have the next one come February 14th to commemorate the World Congenital Heart Day. We expect that you would invite your friends, family members, and everyone, so that together we would learn. There was something Damilola said, one of the speakers, the testimonials we took, that a lot of people did not even know what was wrong with her. Some people had advised that she goes for deliverance or something. Maybe it was a spiritual problem. So the ignorance, the level of ignorance is a lot in our nation, in Africa. Please share the flyers when you start getting it. We would also send in a survey to your email. All of our participants, you will get the link to the recorded version of this webinar, and you will get a survey. We employ you to kindly fill out those surveys. It will just take about 5 minutes or less. We would like to know how to serve you better in the next webinar, and we hope that we will continue to build a family and a strong network of people that are bringing change to children living with congenital heart defects. Thank you so much for your time. And with that, we sign out from today's webinar. All of our technical team members, we love you. Thank you, everyone working behind the scene. Thank you so much for making today a beautiful time. Thank you. Dr. Monigo. Bye, everyone. Oh, great. You can reach us. These are our contacts. You want to do a screenshot? Of course, you get all of this too. Yeah. Follow us on our social media platform, and we would be willing and ready to serve you. Thank you.
Thank you.
Doctor said that she has hole in the heart. When I diagnosed, the doctor told me, the first hospital that we went, they said she has hole in the chest because I've not been hit before. I was shocked. And so the doctor said that there is nothing he can do, that the next level is to do her surgery. To understand that it's not in Nigeria, it's outside. When I heard this information, I was very happy. I believe God answered my prayer because I don't have anybody to help me. So when I see this program, I was very happy. I said, God has answered my prayer.